many of us, including myself, sometimes get confused about pathology report. And to be very open, I actually got a phone call from clinicians, sometimes well-known, very smart, very established clinician call me, what is this about the report? So it's a confusing document, and I understand the frustration, and sorry, we are still on our way to make our pathology report better to be understandable for all the people, including, most importantly, our patient. But I do want to highlight that because pathology report serve multiple functions. It's a very important piece of medical record. It needs to be very accurate. And also, it's an important tool to communicate with other doctors, including other pathologists in other hospitals. And if you transfer your care from one place to the other, different surgeons, they make their decision based on the report. So we have to put a lot of information there. And it's also a legal document. So it is important we document what actually happened to this patient, what tissue exactly be taken out and examined, what kind of tests we perform. So it's important for billing and also important for be tracking if there's any legal issue need to be involved. So with that in mind, you can understand that there's a lot of terms and part of the pathology report not necessarily written in patient language. Sorry about that, but I think with my 10 minutes introduction today, I hope I can give you a structure how to look at the pathology report. So you have a big picture in your mind. And when it comes to details about certain disease features, and that will be a discussion in depth with your doctor. So in general, any pathology report, you can get prostate, non-prostate, benign tumor. There's basically 5 components in any report. They can look very different from the surface, but this is basically 5 components you can see. First, most important thing is the patient information. You know, your name, your date of birth, what time of the tissue was taken out from your body. Those kind of things are essential because it's essential to not mixing up different specimens. And then I think most of us here care about today is the diagnosis and the comment. What kind of cancer, what kind, maybe not cancer, and what features in this cancer we are looking at. But also importantly, but probably not, we don't read it that often as a patient, is a gross description addendum. So gross description or specimen received are basically a section describing what tissue we received in pathology by my eyes. So for example, did my surgeon give me an intact piece of prostate, or did they give me fragments of prostate? Did they tell me they give me a gallbladder and what I actually received is debris? You know, so those kind of things, I have to make sure what I received on pathology matching the surgical document, like your op report. And finally, addendum. So sometimes after we sign out the case, and then we decided, oh, we want to send this test out for a molecular test, or we want to do a different ancillary test. So those didn't change the diagnosis, but we have to document our pathology material was sent out for those tests. Those are addendum. So this is an actual UCSF report for a localized prostate biopsy. And I have to say that UCSF actually issued probably the most sophisticated pathology report. A lot of time in other institutions, the same material might just get 1 page of report. And the reason is we put a lot of information and to help our clinician to make their treatment plan. And we actually take really proud of that. And if you can understand a UCSF pathology report, I think you're probably fine everywhere. So with that 5 components in your mind, you can see that, on the top is always the patient information. And then we put diagnosis, and then we put comment regarding the tumor features in the comments. And then the last 2 pages of the report, you can see the gross description, which we probably don't spend too much time on that, but that is likely to be in a document. So patient information, very important. And if you want to know who you want to blame for a very slow report, you can find their name there because we have to sign our signature at the end of the report. So, Dr. Ding, you're so slow on my report. Now you know. Okay. So how do you know if the report changed? So, sometimes we get some typos. Sometimes I just lost my mind, and error is human, right? So if I found I have an error in my report, I have to amend it. I have to document when did I amend it? Why did I correct it? So to avoid confusion, we typically, the electric and medical record will hide the error report, and they will put a corrected report in the system so no one get confused. But the wrong report is always in the document. And so if you are wondering whether your report was changed at some time by someone, and you check the top part of the report, say if it's amended, and the timestamp is the time I changed the report, and who changed the report will have the electric signature on that. And I have to put in the comment, like, what is the reason I changed the report? So, like in this case, I probably typed the Gleason score wrong. So I say it is corrected to the correct score. And I notify the urologist, say, I'm sorry, I made a mistake. I document when and how I communicate with my urologist. Okay, so now the key part of the pathology report. What is the diagnosis? So you can typically think about any tumor diagnosis into 3 categories. Benign, you don't see any tumor. Atypical, you see something suspicious. And cancer, right? So benign, we often specify what kind of tissue we see under microscope because, by our bare eyes, they're just like a strip of tissue, but it can be prostate, it can be from seminal vesicle, it can be from lymph node. So that's important information for your surgeon to know where did they put their needle in. And if I say something atypical, in prostate, usually you see 2 language that's interchangeable. A lot of pathologists call atypical focus ASAP, or atypical small acinar proliferation. And some of pathologists call these kind of focus called rare atypical glands. They are the same thing. So basically what that means is that there are small focus. There are some features suggestive of cancer, but not diagnostic. So it's suspicious, but we couldn't push more further to put our C word on that small focus. And it often represents, if proved to be cancer, a low grade, the cancer that we don't want to find actually. So we put a flag there, say, well, there's something atypical. However, it's probably not high risk. And it's conscious judgment, like, if this is in a patient with like PSA 200, you probably want to rebiopsy the patient. But, if this is in a screening, and you probably can just follow up the patient with other clinical information. So ASAP, rare atypical glands are interchangeable terms for atypical category. And for cancer, most common prostate cancer is prostatic adenocarcinoma. So there are some other rare subtypes, including ductal carcinoma, small cell neuroendocrine carcinoma, basal cell carcinoma, etc. And sometimes, unfortunately, there's other cancer could spread into prostate, like melanoma, like bladder cancer, like urothelial carcinoma. So different flavor of cancer, but that's important because that impacts treatment decision and management plan. So, okay. And then we often put a Gleason score on the top line, and there's a lot of numbers. They get very confused. I often get phone call from patient or from patient's family, like, what is Gleason score? What is grade group? What is Gleason pattern? And they are all numbers. So I'll go to the detail in this a little bit. And there's also other related terms that even make this thing more confusing, like intraductal carcinoma and atypical intraductal proliferation. They both have ductal. What does that mean? And then there's also high grade. Oh, high grade sounds really high risk. High grade PIN. Like, did I have something really terrible? So let me go into detail of these terms. So Gleason score are developed by Dr. Gleason. Basically, he separated, it's actually a team, but including Dr. Gleason, separate tumor prostate cancer into 5 different pattern groups. And now we don't call anything 1 and 2. So you practically only see Gleason pattern 3 and 4 and 5 in your report in a modern prostate biopsy. And basically a score is a summary of 2 most prevalent patterns in the tumor. So if the most prevalent pattern is pattern 3, and the second most prevalent pattern is pattern 4, you get a score of 3 plus 4 equal to 7. And this number is very confusing because 3 plus 4 equal to 7 doesn't equal to 4 plus 3 equal to 7. They are pretty different. So that's why later on people decided, well, maybe let's make things easier. Let's put it into grade group. So, by different combination, you can basically get 5 different scores. 3 plus 3 equals to 6 versus 5 plus 5 equals to 10. And we basically group that into 5 groups. So basically larger the number means more aggressively the tumor look under the microscope. Whether they are truly aggressive is actually a combination of pathology and also clinical information. So don't freak out just because you see a large number in your report. However, in general, the sense is that you can group different score into 5 groups, so it's easier to understand the prognosis. And just briefly, what are the difference of these 3 terms that you can see in your prostate biopsy report? So intraductal carcinoma is still controversial whether we grade them into Gleason grading. In UCSF, we grade them together with Gleason. However, intraductal carcinoma alone as a pattern is a high-risk pattern that is almost like a red flag. So if we put that in the report, the clinician know, even though the Gleason score looks low, like 3 plus 4, this patient may need some more additional follow-up. So that's what it means. And a typical intraductal proliferation, or AIP, are lesions. You see the word atypical, so like what pathologists are thinking now. They are thinking things almost look like intraductal carcinoma, IDCP. However, not yet. It's suspicious, but not diagnostic. So you basically put a flag there thinking, well, I'm worried this patient might have a high-risk pattern, but I'm not that sure. So I put a flag there, so we keep follow-up. And this is pretty much only applicable in biopsy. And finally, high-grade intraepithelial lesion. So the history of this is that this is considered a pre-cancer lesion. They have some feature overlapping with cancer, but nowadays we know these almost have no clinical significance. If this is the only thing you have in your report, you can basically think you have a benign disease, unless your PSA is crazy or you have a crazy MRI. So in short, don't worry about high-grade PIN. Talk to your clinician if you have an AIP, and if you have an IDCP, you probably want a second opinion on other pathologists because it's a really high-risk pattern. Okay. So just briefly, we put a lot of information in our comment at UCSF. And if there's one thing you really want to look at, I will recommend you to look at the section comment on Gleason pattern 4. Because Gleason pattern 4, although they are 4, there are actually multiple different patterns, and some of them are more aggressive than others. And one of the common aggressive pattern is actually large cribriform. So you want to show your doctor you're very smart reading your report. Say, whoa, I see no large cribriform in my report. I'm probably okay, right? And then your doctor might tell you, well, but you have to consider your clinical presentation and other lab tests, etc. So make your conversation sound a little smarter. Look at this part. And other part include very detailed of like tumor volume in each core, whether they involve new nerve, whether they are involving extra prostatic tissue, etc. So it's a lot of information, and you can take your time reading it. And there are also some language here you will feel like, well, how is this relevant to me? So these are basically comments I write for my coders when they see the document, they know what test I perform and how do they charge per report. So you don't have to put a lot of attention on those segments. Okay, so finally, I do want to touch a little bit on gross description. You want to make sure how many tissue core the clinician take away from you is diagnosed. So we want to make sure the number match. For example, here there are 8 parts of prostate examined at pathology. So you want to make sure that number match. And finally, if your tissue block is sent out for a molecular test, we document it as addendum. So it can be updated after the case is signed out. So you can check your electronic medical record periodically to see if there's any more tests done by your clinician or by your request. So this is the pathology 101. Hopefully that's helpful, and happy to take any question. Thank you.